welcome. This is the webinar series, Sight and Sound Bites from the Eye and Ear Foundation. We've been doing this webinar series, every other week for now since 2021, and honestly, we have a tremendous response to these, and we have a lot of people who view them online, and we're very happy to share the content that we're going to be providing today on a topic that is, as I said, very, very popular and unfortunately very prevalent in society in causing vision loss. So we're going to talk about age-related macular degeneration and geographic atrophy, and we're going to talk about the clinical impacts and clinical updates, as well as research that's going on here at the University of Pittsburgh. So the Eye and Ear Foundation, I'm the CEO, Lawton Snyder of the Eye and Ear Foundation. We support research in vision, but also hearing, voice, cancers of the head and neck, balance disorders, and sinonasal disorders here at the University of Pittsburgh. We are a 501c3 nonprofit organization, and we bring this to you free of charge, of course, but we certainly appreciate philanthropic support, which is very important for the mission and everything that you're going to hear about today. A lot of the research that goes on here is supported by the Eye and Ear Foundation. Certainly, we play a pivotal role in making sure that we advance the care for all of you that are dealing with these conditions. So a few housekeeping things before I introduce our speakers. So we will have chat disabled. So you'll see chat on here, and a lot of people like to chat, I know, when we're on webinars, but we don't have that available for you. But we want you to engage with us, and the way to do that is to ask questions. So go to your Q&A button on the bottom, click on that, and type away a question anytime you like. At the end of the program, I'm going to read the questions to our panelists, and we'll get a conversation going about what we have, what you hear presented. We also have a nice feature on here for captions. For those of you who need to use the closed captions, you can click on that, and then we will answer all your questions. But I will tell you that if you are asking questions that are kind of more personal health questions that I think would be better to answer offline, and we skip your question, don't be offended. We'll get to it later. We will make sure we answer everybody's questions. Okay, let me go ahead and make the introductions. The first speaker is going to be Dr. Kunal Dansingani, who is a clinical retina specialist here at the Vision Institute and associate professor at the University of Pittsburgh. And he's going to talk about the condition for macular degeneration. And then Dr. John Ash, who is our vice chair of research in the Department of Ophthalmology, and also the Ron Salvitti Chair of Ophthalmology at the University of Pittsburgh. So we're ready to get rolling, and I think Dr. Dansingani is going to go first. So please, Dr. Dansingani, take it away.
Thank you. Thanks for the introduction. Pleasure to be here. So I'm a retina specialist. I see patients with surgical problems, but also with medical retina problems. In the non-surgical group, I'd say that age-related macular degeneration accounts for probably about 40% of the practice. So it's an impactful condition. It's a condition that's important to all of us. And in addition to clinical duties, I have some research interests related to macular degeneration, which are in the area of imaging. So I'll show you a little bit of imaging in the course of this talk as well. So age-related macular degeneration is prevalent. It's age-related, and it affects 1 in 8 people over 60. Worldwide, there are about 200 million people affected, and that's projected to increase by 2040 to about 300 million. So quite a prevalent condition, quite a debilitating condition, because it interacts with other chronic diseases as well. It's a degeneration, which means that it is chronic and it is progressive. It's not curable. It's not reversible. It damages the architecture of the tissue in the retina. And the retina is a place where there isn't really any redundant tissue. So tissue lost and cells lost result in loss of function. Importantly, it's not universal. Not everyone gets age-related macular degeneration. It seems that there are risk factors that increase its incidence. And really, because it's not universal, we like to think that there must be a way to slow it down or to prevent it, or at least to prevent its worst manifestations. And that's where a lot of research effort is directed. It's a macular degeneration. So what's the macula? To understand that, we need to look at some anatomy. So here's an eye in cross-section, and it's sliced open and viewed from the top. A lot of the structures at the front of the eye here are optical structures, and they are geared towards focusing light and providing optimally focused light and an optimal view of the world, which is then focused on the retina, which lines the inside of the back of the eye. Now, the back of the eye has been peeled open here, so I want you to notice that on the outside, the white of the eye is the sclera, and there are actually multiple layers to the back of the eye. This layer is the choroid, and then this layer is the retina itself. There are actually more layers than that, but we could spend an hour just talking about the layers. This is sufficient for now, just to understand that there are several layers involved. That becomes important in understanding the imaging. The very central part of the retina here is the macula, and the very central part of the macula is the fovea. When we look at the back of the eye from the front with a camera, we see something like this. And what we're actually seeing here is that we're seeing light which is reflected off the sclera, which is the white part of the eye from the inside, but the light is tinted into an orange kind of color by the presence of a dense network of blood vessels in the choroid. The retina itself is actually very transparent, so you don't really see the retina. What you do see is the blood vessels of the retina, and these are the important blood vessels which are called the superior arcade and the inferior arcade, which are anatomical landmarks. Here's the optic nerve. And the macula itself refers to this region, which is approximately bounded by the superior and inferior arcade. From a vision perspective, this area corresponds to the very central part of vision. So this is the part of the retina that you use when you look at someone, talk to someone, recognize their face. It's the part of the retina you use for reading road signs or for reading a book. So although it's a small region of the retina, it is disproportionately impactful when something goes wrong in this area. Now, this is a color photograph of the retina, but we have an imaging technique called optical coherence tomography, which allows us to capture a three-dimensional cuboidal image using infrared light. Once we have a three-dimensional image, we can slice it in different directions. We usually slice it horizontally, and that gives us a cross-sectional image of the retina that looks like this. So this is a conventional way of looking at OCT of the retina. OCT is a real workhorse kind of imaging technique in the retina clinic. Almost everyone who comes with a macular condition will have an OCT during their visit. OCT is a high-resolution imaging technique. It doesn't quite show us individual cells in most cases, but it almost does. But it certainly shows us the component layers of the retina in very high resolution. So this is the front, and this is the back. And I'm going to be showing you some OCT scans to explain some of the disease patterns. So one question that patients often ask when they come, they're referred by their general ophthalmologist, by their optometrist, and they're told that they have drusen. What are drusen? Drusen are little yellow deposits that accumulate often in the macular area, but sometimes elsewhere. And you see them here as these kind of granular little yellow-white deposits. They're not directly under the retina, but they're under the next layer underneath, which is called the pigment epithelium. And you can think about drusen as metabolic products of the retina that the eye has been unable to clear away. So they're accumulations, and they represent some kind of dysfunction in terms of metabolism and the clearance away of waste products. By themselves, if they're small and if they're few, they don't necessarily constitute macular degeneration, but they can be a precursor to macular degeneration, particularly if they're large. They come in different sizes and distributions. And when you look at them on the OCT, they look like little bumps under the retina, like you see here and here. And you see that the eye in the top picture only has a few scant drusen. The eye in the middle has only one significant drusen-like structure, whereas the eye at the bottom has a whole cluster of drusen, including some outside the very central part of the macula. So they come in different sizes, they come in different distributions, and they have a kind of evolution that they go through. Drusen can come and go, and they can change, and they can become visually significant. So what happens? Here's a picture of an eye with larger drusen. When drusen become large like this, then this is then no longer called early macular degeneration. This is called intermediate macular degeneration. This is a set of OCT scans of various drusen, and you can see from this that these bumps under the retina, these elevations, they can come in different sizes. When they become coalescent, they can form these very large deposits, and some drusen can really become quite huge. Now, this is a very large drusen. Drusenoid PED is another name for a very large drusen. Now, what do they do? Well, sometimes drusen can be associated with some early atrophy. And atrophy is a word which refers to cell loss. So if you look at the left-hand side of this picture, you'll see that in this deep part of the retina, the layering of the retina is fairly intact. You see that there are some drusenoid deposits, but if you look at the right-hand third of the picture, you see that some of the layering that you see here on the left is actually lost. And there are even small locations like here where the layering of the retina is completely lost. And that's because there is actually a loss of cells of the pigment epithelium and of the retina in this region. So this is an example of atrophy. In this picture, it's a little bit early and mild because it's not that extensive. But when atrophy occurs, it means that that tiny patch of retina is not functioning correctly, and that has implications for vision. Now, geographic atrophy is when atrophy occurs in contiguous zones. And these contiguous zones typically get larger over time. What you're seeing here is a defect. What you're seeing is not a defect in the retina. What you're seeing is a defect in the layer behind the retina, which is the pigment epithelium. But we also know that when the pigment epithelium dies in a particular region, that the photoreceptors of the retina are unable to survive. So we can infer from looking at geographic atrophy of the pigment epithelium that there is retinal involvement. And when there is contiguous involvement like this, these zones of geographic atrophy actually manifest as blind spots in the patient's vision. Now, geographic atrophy comes in different patterns as well. There's geographic atrophy, which is fairly plain, where you don't see a lot of drusen in the eye. But there's also geographic atrophy in the lower left pictures, which occurs amid drusen. And so this becomes an important consideration when we're looking at different treatments, because not all geographic atrophy is the same. I'm going to introduce you to another imaging modality here. So this is a color photograph of a macula here with zones of geographic atrophy. And there are lots of drusen in this eye. The image on the right is an autofluorescence image. Now, the autofluorescence image doesn't actually image the retina. it images the pigment epithelium, which is the layer behind the retina. The gray and bright areas are where the pigment epithelium is intact, and the dark areas are where the pigment epithelium cells have been lost. Now, the other thing about autofluorescence is that it's not actually imaging cells themselves, it's imaging the distribution of certain molecules within those cells which produce an autofluorescent signal. But because it gives such a high contrast image, it can be quite a good way of following an eye for progression. So here's an example of progression. This is geographic atrophy at year 1 of presentation. And if you look through years 3 and year 5, you can see that the zones of geographic atrophy typically become larger over time. In some patients, this can happen quite quickly. In some patients, it can happen quite slowly. Now, not all geographic atrophy just arises and grows like this. There are some types of geographic atrophy which occur in the setting of large drusen, which I'll show you in a moment. Now, this is an OCT scan of geographic atrophy. And the thing to notice here is that there is light shining through the pigment epithelial layer. So where you see this kind of excess light shining through into the deeper structures, that tells you where the pigment epithelium has been lost. And you can also see that the layering of the retina is lost at the margins of the geographic atrophy. But the location where the edge of atrophy is with respect to the retina is not always the same as where it is with respect to the pigment epithelium. This is an example of atrophy, geographic atrophy, which has arisen in the setting of a large drusen deposit, which has subsequently disappeared, and it has left a legacy of atrophy in the retina. So that's one major pattern of disease and vision impairment in macular degeneration, what people refer to as the most advanced form of dry macular degeneration. This is now an example of neovascularization. Neovascularization is what people refer to as wet macular degeneration or the wet complications of macular degeneration. And it's also one of the causes of advanced disease and vision loss. Now, the choroid is a layer of blood vessels which is deep to the pigment epithelium. And this is basically a dense meshwork of blood vessels. This is what gives the fundus, this is what gives the photograph of the back of the eye the orange tint. And what happens in wet complications is that blood vessels, which are supposed to be confined in the choroid, instead start to invade other layers where they don't belong. So here what you see is an elevation of the pigment epithelium, and within this elevation, we know that there's a network of abnormal blood vessels that have grown and invaded that space. And we know that there are blood vessels there because those blood vessels are leaking fluid, and that fluid is this dark kind of cleft, which is flanking this pigment epithelial elevation. And this is the fluid which gives wet disease its colloquial name, and this is what we have treatment for. Now, if this is left untreated, then it can lead to, well, it leads to distortion. Distortion is a very important symptom for patients to report. It can be an early symptom. It can allow us to diagnose this condition early. If this condition is left untreated, it leads to bad outcomes. So this is a photograph of an eye which has experienced scarring in the central part of the macula. Here, where the retina looks white, it looks white and gray because it's lost its transparency. And the abnormal blood vessels here under the pigment epithelium have not just leaked fluid, but they've actually frankly bled. And what you see here is flanking blood, which has made its way into the space under the retina. Blood in this space is bad news because it leads to scarring. Scarring replaces normal tissue with scar tissue, and scar tissue doesn't serve visual function well at all. So this also leads to a very distorted blind spot in the central vision of the patient. Fortunately, we have treatment for neovascularization. You may have come across the names of some of these medications before. These are the traditional medications which inhibit a molecule called VEGF. The thing is that once abnormal blood vessels have made their way into those spaces where they don't belong, they don't disappear completely. They have to be constantly suppressed, and that's why all of these treatments need to be repeated, initially on a monthly basis, but sometimes when disease comes under control, we can spread out the injections to a couple of months or sometimes even 3 months between injections. You might have heard of a newer medication called faricimab. This inhibits two molecules. It inhibits VEGF, but it also inhibits angiopoietin-2. So it has the effect of stabilizing some of the abnormal blood vessels. Stabilizing is a good thing because it makes them less likely to leak and to bleed, but we're still learning how best to use this medication, and it might be the case that it's not the best drug to use in the very early stages of treatment. It may be a better one to use for switching medication once the initial disease is under control. But this is treatment for wet forms of macular degeneration. This is a image just to show you what happens. Look at the lower third of the image first. These are OCT scans at baseline and after treatment. And what you see is that this cleft of fluid under the retina regresses after the first injection. There's very little fluid left here, and it regresses even further after the second injection. But the abnormal elevation of the pigment epithelium persists. And this is a technique called OCT angiography in the top part of the image. And what this is a type of OCT that highlights blood vessels. And this is a view taken from the front rather than the side. But really what this image shows you is that even after a period of treatment, the blood vessels do regress, but they don't go away completely. They do persist in some form, and they have the potential to reactivate, requiring constant treatment. So this is a summary of the major disease patterns. Small drusen by themselves don't necessarily amount to macular degeneration, but medium and large drusen do, especially if there are also changes to the pigment epithelium. And this corresponds with early and intermediate macular degeneration, which has the potential to convert into one or both of these advanced disease patterns, either the geographic atrophy or the neovascularization with hemorrhage, or even both. Importantly, these two patterns are not mutually exclusive. They can occur in the same eye. And this is an example here. So if you look at the top half of the macula, you see that there is geographic atrophy, which enlarges over time. But if you look at the lower half of the macula, you see that there's some early scarring here, which becomes more established. There's this grayish appearance, which is a scar. And here we see a mature scar in the third image, even with some flanking hemorrhages around it. So this is two patterns of advanced disease in the same eye. Now, that's treatment for wet complications of macular degeneration. But what about treatment for dry macular degeneration? Until recently, we haven't had any effective treatment. Going to change tack a little bit and just explain what complement is. Complement is a system of molecules which is there in the body, in all parts of the body. It's a system of molecules which is considered to be part of the innate immune system. And it's a system of molecules where molecules can activate each other in a sequence, a bit like a kind of domino sequence. There are various triggering factors which can set off the sequence on the left side of the picture. And these can be certain kinds of infection or certain kinds of foreign body coming into contact with the body. And these are the types of events which can set off the activation of the complement cascade. The molecules of the complement cascade have names like C3 and C5 and complement factor H and complement factor B. But basically, they activate each other in a sequential domino-like effect, which culminates in the formation of this thing, which is a membrane attack complex. So this is a tubular molecule which can insert itself into the cell membrane of a bacterium or any kind of offending cell. And by punching a hole in the cell membrane, it can cause the contents to leak out and it can cause cell death. So this is part of the innate immune system. Now, it turns out that certain patients who develop macular degeneration have certain genetic variations in the genes that code for these complement components. And that has led to the hypothesis that perhaps complement cascade activation might be one of the factors which is causing the demise of cells in macular degeneration. And perhaps therapeutic intervention, which is targeted at putting the brakes on the complement cascade, might be a way of treating dry forms of macular degeneration. So you may have heard of these medications that were FDA approved last year. Well, Izervay was approved, I think, this year, but Syfovre was FDA cleared last year after a phase 3 clinical trial. Syfovre targets C3 and Izervay targets C5 in the complement cascade. Now, the phase 3 clinical trial of Syfovre or pegcetacoplan, that showed a reduction in the speed of enlargement of geographic atrophy by about 20% after 2 years of treatment. Now, it didn't stop the growth of these areas of geographic atrophy, it just slowed them down. And over a period of 2 years, what it meant was that patients in the treated group had a few months longer before reaching the same degree of atrophy compared with patients in the non-treated group. There were some limitations to the study. One was that it used autofluorescence as the imaging technique, and there's been a little bit of controversy in the retina community over what that actually represents. But the main issues with the treatment, which have resulted in not that much uptake, at least in our clinics at the moment. One is that it commits a patient to monthly or 2 monthly injections indefinitely. The other important thing is that in the treated group compared with the non-treated group, the study was not able to show any functional benefit. Functional benefit means visual acuity, reading speed, and various tasks that require fine macular vision. The treatment was not able to show a benefit at 2 years. Now, my understanding is that there is some 3-year data coming out, and we have an important conference in Seattle next week at which some additional data, I gather, might be presented. I'm not sure what to expect, though. Another concern was that by treating the dry macular degeneration, it seemed that there was a risk of exacerbating the neovascular component of the disease, the wet component of the disease, in about 12% of subjects. There was also a small risk of inflammatory complications, and there was an attrition rate of up to 30%. Something like 1 in 3 patients ended up leaving the study prematurely, not necessarily because of complications, but I gather because of the treatment burden and the lack of functional benefit. So that's my latest understanding. I've been discussing these findings with all of the patients who come to see me who might be candidates for pegcetacoplan or for these new medications. So far in my practice, I've not had any patients initiate this treatment. But I think this is a good point at which to hand over to Dr. Ash, who's a lot more knowledgeable about complement and complement genetics.
Thank you. I'm very, very happy to be here and to talk to you about what's going on. First of all, as the background, you can see our new Vision Institute, UPMC Mercy Vision Institute. And this is where a lot of the clinical work that you just heard about, but also the research that I'm going to talk about now takes place in this building. The research clinic is in this part of the building, and the research is in the upper part of the building. Let me get the pointer turned on. There we go. Yeah, so the research primarily takes place in these upper floors on the top levels of the building. So really excited to be moving in this space. It's really helped us bring the entire department together. And, we have more conversations with clinicians and scientists as we've ever had before. And also we have all the scientists in one space. So this has really been a big help for us. So as you just heard, AMD really can be broken down in different stages of diseases. We heard about early with small drusen, intermediate with larger drusen, and then we heard the late stages, the geographic atrophy and the wet AMD. I'm not really going to talk too much about these late stages, but really I want to introduce the concept that really the target for therapy, what we really need to develop new therapies for, are these early and intermediate stages. First of all, we're never going to really fully restore vision once it's lost. So what we have to do is prevent the initial loss of vision. And so targeting these early and intermediate stages of patients still will have useful vision. And as long as we can maintain that vision, we can introduce new therapies that essentially may prevent AMD from progressing and prevent people from loss of vision. So it's really, this is an area where I think we need to start really focusing on therapy development. And we'll talk a little bit about this GA and the new reason for looking at the complement inhibitors. So this is just another example of, I won't go too much into it, but example of the autofluorescence imaging looking at progression in 3 different patients of GA. It really doesn't always progress at the same rate. Although some patients progress quite rapidly. And so you really want to be able to slow that progression down. And so drug companies have come to develop 2 new compounds which can target complement cascade or complement activation. An idea, hopefully, to slow it down. Although the effectiveness of that treatment is not clear yet. The reason why they picked that is these are actually data from 2 very large genome-wide association studies. They looked at the DNA of normal patients and patients with AMD to identify what are the DNA changes that are strongly associated with having the disease. So trying to look for the genetic cause or the genetic links to what AMD is. And I've kind of put boxes around so a few of these genes, and haven't highlighted all of them, but here those that are circled there indicate genes that are involved in the complement cascade. So many targets for the complement cascade came up in these genome-wide association studies, have really led to the idea that these are in fact maybe going to be very important targets for preventing disease, that late stage disease. The interesting thing about that is the very first gene we ever identified was complement factor H, which is an inhibitor of complement activation. And loss of function of that inhibitor led to the idea that overactivation of complement is really one of the primary causes of disease. So that whole story has led to this, we should target the complement cascade. A lot of research jumped onto that. But there are actually 62 genes now that we know of have changes in them that are strongly associated with disease. So we have a lot more work to do and a lot more pathways. Not all of those are involved in complement. In fact, many are not. So we actually have a lot more work to do in identifying what those genes are and what role they play in developing diseases. Now, I've just sort of highlighted in yellow some of the complement genes that are in the cascade. There are a large number of genes in the complement system. And you can see the ones in yellow are the ones associated with AMD. And those are, really a large percentage of the complement cascade are involved in that disease. So there's really a good logic for targeting it. And drug companies and scientists have got together, maybe if we target this enzyme complex known as C3 convertase, or this other enzyme C5 convertase, if we block that, then maybe we'll actually be able to prevent the disease. And that was the basis for doing that. And really what these are, this is a roadmap of the complement cascade, really getting into the weeds here, but so don't try to memorize this in any kind of way. But as you heard a moment ago, the membrane attack complex at the bottom, that's the bad guy. Once you leave that activation, that causes death of the cell. And really what we need to look at in this cascade is how can we inhibit, the drug companies have made C3 convertases, C5 convertase inhibitors, and that has some marginal effect, but not large. many of the mutations that are involved in AMD are actually not in the downstream events, but many of them are in these upstream effectors. And so maybe the new target should be moved from these convertases, which seem like a very quick target, but actually looking at ways that we could prevent this initial tick over up here. So I think there's opportunity for new therapy to develop a slow progression that doesn't involve these major convertases, but does involve this very early activation pathway through the alternative pathway. The reason why it may be important to target this area of the pathway rather than the convertase is because this is a very important mechanism of our defense against foreign invasion from bacteria or viruses or even tissue damage. And so we don't really want to be cautious about completely inhibiting it, these effective molecules. However, this alternative pathway, it seems like we could more specifically target this part of the pathway, and then that may be a better approach. So several of us, including work in my lab, is we're working on ways that we can actually regulate this pathway better as opposed to targeting these C3 and C5 convertases. So we're still working on the complement pathway. I don't think it's not a good target. I just think sometimes we pick some of these major players, these major events, these convertases, and we're maybe a little bit too late in the game. The other thing is, these were easy targets, so that's the first ones you go for. Working up in here is a little more difficult and challenging, and so that's why we're a little bit behind in developing those. So that's another area of work, is to try and catch up with these big convertase areas, and maybe we can develop earlier therapies for AMD. So if you really want to understand, that's for GA, if we really want to understand how to maintain this useful vision longer, we need to look at the genetics and look at the risk factors that are associated with that progression. This really is the progression from early to intermediate and then to a late phase. Roughly 90% of the AMD patients are just caught up in this area of early and intermediate AMD. This is actually a very large patient population that have potential for therapies to prevent that progression. So we're really interested in looking at this. These are late phases, are about 10% of the population. So I think targeting the late stages is important, but I think, really the biggest hit we can have is targeting these earlier phases. So if you look at the genetics, there are, I told you, 60 different genes and close to I think 63 different nucleotide changes that are associated with disease. I think it's 82, sorry. They're associated with disease. So it's really a complex genetic diseases, and they're spread out across many of our chromosomes, not all of them, but most. So it's possible for patients to inherit not just one gene, but multiple genes that are associated with AMD. It depends upon how frequent those different, we call them alleles, but how frequently they are in the population. And in European populations, they're actually quite high. So European descendants, many of us are Caucasian in the United States, those frequency of those risk alleles can be quite high. So you can have combinations of risk alleles that if you add up each of those alleles together from those different chromosomes, you can get a risk factor, a genetic risk factor. If you have multiple high risk DNA changes, we'll lump you into a group that's called high genetic risk. If you have low genetic risk, you can be lumped into a group that's called low genetic risk factors. So really, this is actually looking at your overall genetic composition of those 62 genes and looking to see whether you fall into a high genetic risk, medium genetic risk, or low genetic risk. But then there's another interesting thing that's come out of the European Consortium, and that is we can predict your relative risk based on the genotype. But if we look at your behavior and how patients their lifestyle choices, then we can get a sense of that there's an overlay between behavior and genetic risk. Excuse me. So that if you have low genetic risk, but you have very high risk behavior, you can have about a 3 to 5-fold increase in risk generating and developing AMD. Likewise, if you have very high genetic risk, but you have very low risk behavior, you can reduce your risk of developing AMD by the same 3 to 4-fold. So it's very clear that we can affect the genetic risk by how we're behaving in our world. Now, what are those lifestyle choices that we're talking about? Some of those are avoiding high-fat diet, high glycemic index diets. Basically, sticking to a Mediterranean diet actually seems to be associated with lower risk. Smoking is increased with high risk, so don't smoke. Taking an ARED supplement, an antioxidant supplement, can lower your risk somewhat. But then also moderate consumption of alcohol, like high consumption of alcohol, can also reduce your risk. So if you're smoking, you're drinking high levels of alcohol, and you're eating this Western diet, your risk behavior all add up to these unfavorable lifestyle, and you can change those behaviors and overall lower that risk. So it's really kind of interesting to understand our behavior and what's going on with the genetics. We can now sort of assign people into their risk, but we can't look at somebody and say, oh, you have high risk behavior and you have high genetic risk. You can't look at that person and 100% accuracy predict, yes, you're going to go on to develop AMD. So we don't do genetic testing for AMD yet, although I think scientifically we should do this a lot more, but we don't yet do that because it doesn't really affect therapy in any way. So we can't really change your therapy by doing the genetic testing, so there's no real need to do it yet. But ultimately, one day we may get to that point. So here's some of the interaction between, there's another recent paper on medRxiv. It's not yet peer reviewed, but it really is an interesting study. They're looking at essentially the risk of behavior with known risk factors and basically those 60 genes. And they're really broken this down into age when you're taking on that behavior. So if you look at, this is really the age of risk of developing AMD, and this is broken down into decades. So there's 45 to 55, 56 to 65 in this group, 66 to 75, and then 76 and higher. And what you notice is that the lines go up, and as you have increased risk of developing the disease or increased incidence of disease. And basically, it's a very large study and represents about 45,000 people involved in the Million Veterans Program. And essentially, so they're mostly male, and they're mostly Europeans and Caucasians. So they're really not the highly represented data, but it certainly represents a group that is at higher risk for AMD. And if you notice, you compare all AMD patients or current smokers or heavy drinkers, there really isn't any difference in risk until you start getting to the end of the end of the 60s. So 60 to 65, they start to become different. So high risk behavior starts to pull away and increase the risk from all AMD patients. So really what that's showing is that as you get older, then that risky behavior becomes even more prominent. So it's important, obviously you can get away with doing things when you're younger, but as we start reaching into that, 60s, 70s, and 80s, we really need to think about those behaviors very clearly, making our choices, because those really can affect it. And there are studies going now looking at Mediterranean diets to see if you can actually switch somebody from a high-risk diet into a low-risk diet, if you can actually reverse or reduce that risk, which is something that's very unique. This is a study going on in Europe at the moment. Another part of this Million Veterans Program data is they looked at some things, medical records, they looked at some of the clinical diagnostics that are associated with risk. And surprisingly, things like high cholesterol was strongly associated with risk, but it wasn't LDL cholesterol, low density cholesterol, that is heart disease. It's high levels of high density cholesterol. So the higher your HDL cholesterol is, the higher the risk for developing AMD is in these patient populations. So obviously, some things are associated with increased risk for heart disease doesn't cause you increased risk for AMD, but if you increase HDL, which we think that's going to protect the heart, it actually can increase your risk for developing AMD. So we have to think carefully about those lifestyle choices and figure out what the metabolites are that are causing that increased risk. The other thing was surprising from this, actually we've reported this before as well, that diabetics actually have a lower risk for developing AMD. And so that has a lot to do with nutrition, we think, as in metabolism, that if you're able to drive more of a glycolytic metabolism, then you're actually maybe able to protect from developing disease. That's still a theory. We don't know the answer to that yet, but it's something that's a work in progress. Not recommending that people become diabetic to reduce their risk of AMD. That's not a good idea. But it does say that there is a definitely link between metabolism and AMD. So understanding the risk in developing therapies, we have genetics, we have age, of course. We're not going to do anything about either of those two until we eventually get to gene therapies, but there's no need for that yet. Behavior is something we could change, and exposure. So people are talking about changing microbiome and are watching our environmental toxins, such as smoking and alcohol. But behavior is part of that as well. So really not clear exactly what we need to intervene and what do we need to take advantage of to lower our risk yet. But clearly, I think reducing smoking and alcohol and moderating our diet are some of the things that we can do almost immediately. In the laboratory, what we're looking at, all right, if all of these things add together and they change abnormal metabolism, and we think that leads to a loss of cellular function, leads to increased oxidative damage, that's where you start to see increased accumulation of drusen, increased inflammation. You might see activation of complement cascade, increased neovascularization, or the blood vessels growing under the RPE, and then you might see loss of vision through cell death. And what we're hoping, though, is we can even further cause decreases in metabolism. So this could be a very vicious cycle. What we're hoping, though, is we could do in the laboratory, or we can study in animals, is that we stop advancing. There we go. We can restore metabolism. If we do that, then we start maintaining cellular function. We reduce oxidative stress. Obviously, that's going to lead to reduced inflammation, and we think that may prevent loss of vision through cell death. So really, one of the things in the lab we're really focusing on is this restoring metabolism as a key event that integrates multiple risk factors into preventing the disease progression. So in the lab, some of the things that we have going on is we're looking at drug therapies. Again, our target here, our new therapies is these early and intermediate AMD stages. And we're developing new drug therapies using some old drugs. So one of them is metformin. It's an anti-diabetic drug, but it actually can increase glucose metabolism even in the retinal. So it actually can protect it. Patients taking metformin in some of these million veteran programs and in some smaller studies that we've done in my lab and other labs, patients taking metformin have reduced risk for developing AMD. So there is some clinical evidence that some of these drugs that can change metabolism can be protective, and more work needs to be done in that. We're also looking at basically cytokines or stress factors that get upregulated this duration, that they actually can slow down the progression. Some of them are called the inhibitory factor or oncostatin M. We develop those as proteins, and we're testing those. But the idea of injecting a protein once a month is really not appealing. I think 30% loss in participation in the study from those kinds of things is really pretty high. So I think patients don't like those frequent injections. So we're trying to develop these as gene therapies that we can put them in. You get one injection, and then you actually have this more chronic protection that might last you for as long as you're walking around. So we're looking at developing some of these other therapies into more gene therapy approaches so that we can lead to longer useful vision. So I think with that, I think that's my last slide. It is. And so I'll stop sharing. Maybe we can move on to questions.
Okay. Boy, thank you both. That was an incredibly thorough and very interesting and look into age-related macular degeneration, geographic atrophy. I think I understand it a lot better every time I hear you guys, and thank you for that. We have a lot of questions, and I have, just starting with some questions myself. I mean, it seems like there's now with some of these discoveries around, the focused on the early onset of the disease, that there's going to be more opportunities for even more drug development than we've already seen already for the geographic atrophy, but maybe even more drug development or other therapies, as you mentioned, John, gene therapies and other things. that can lead to better slowing the progression and even halting the progression of the disease early. Um, uh, what are the focus what we're doing specifically at Pitt that kind of speaks to that? And are there ways that we can even find out earlier and earlier if we're at risk for this? So there are things that we can start to enhance in terms of how we visualize and see the cells and know earlier what's happening.
So that's one of the topics in the field, and it's actually one of the problems with protective therapies is you need to be able to predict which patients are going to get the disease before they get it, and you need to predict how fast they're going to progress so that you can know that your intervention has an effect. And I think you'll find that in the field, it's really hard to look at a patient to know who's going to get it. Even if they have those small drusen, you don't know that they're actually going to go on to get disease. If they have the intermediate drusen, it becomes, as they progress and get further down the line, it becomes easier to make that prediction. And in fact, that's why the late stage diseases were the first therapeutic targets. One is they're cause the most blindness, they're the most severe. And two, it's easier to predict that transition to loss of vision. These early stages are harder to target because it's harder to track the patient and to know whether they're going to progress or not. But the development of new imaging technologies and imaging modalities and some physiological tests, such as a dark adaptation that's coming up, which is an ERG physiological test, there are inroads being made into making better predictive using artificial intelligence or better predictive algorithms, integrating the genetics and the behavior with these imaging modalities to make better predictions about patient progression, patient risk, and patient progression. So that's kind of the hot area of the field right now, is to integrate those multiple modalities, genetics, metabolism, or behavior with the imaging, and then integrating that and making predictions about progression. That's really needed.
Thank you. It obviously is an exciting time, I think, for the field. What percentage of macular degeneration turns into geographic atrophy? And I think Dr. Dansingani, I think you described that well, but is there a percentage, and is it usually dry or wet or both that you feel?
It's actually difficult to put a precise number to it because the numbers vary quite a bit among studies. It may be as high as 50% of patients with intermediate macular degeneration developing one or both of the advanced complications. It may be as low as 10%, depending on which studies you read. And the heterogeneity is going to be there partly because of geography, ethnicity, genetic factors, a lot of the lifestyle factors, a lot of the things that Dr. Ash was explaining.
Yeah, and I see that's one of the questions here as well, is, what are the preventative measures? And I think, you guys have hit it well. Essentially, pick your parents well, and then after that, really, eat well and exercise and don't smoke and, consume alcohol moderately, right? So if we're looking at clinical trials that we have happening, do we have any clinical trials that are happening currently at the University of Pittsburgh?
As far as I know, we're not involved in any of the big studies of the new molecules, but we are early adopters of the new treatment. So all the medications that I explained, we have those available in the department.
Okay, great. How important is genetics, family history, to developing age-related macular degeneration?
So Caucasians have the greatest risk, and that is largely due to the genetic prevalence of the DNA changes that are associated with increased risk. And so that's one of the reasons is that, this is not strictly speaking this, but there's really much higher risk, I think a threefold increased risk if you're European descendant. And the lowest risk is if you're from Africa. That's really one of the lowest risks for developing this disease. But, you have a lot of mixed populations, African Americans, right? And then your risk depends upon which of those risk genes you get from the European ancestry and which genes you get from the African ancestry. So understanding the genetics is really, I think that's the next step in making that prediction. And it's getting less and less expensive to do that. I think we should, even though we can't affect treatment, I think we should start to think about how do we do genetic testing for patients that are getting, we start seeing small drusen. We need to start thinking about genetic testing to try and figure out the risk and behavior assessments.
Very interesting. So can drusen be permanently reduced by statin therapies or statin drugs?
I don't think so. It's not a treatment paradigm to put patients with drusen on statins.
Right. And go ahead, John.
No, I was going to say statins are really affecting some of the lipid metabolism, like cholesterol and things like that. And drusen is far more than just cholesterol accumulation. It's really a loss of function of the RPE and the immune system, which leads to the accumulation of that material there. So it's not like it's a clot that you might form in a coronary artery or something. It's a very different composition and a very different reason why it's there. So that's one of the reasons why the statins don't particularly help.
No, and the question was about statin, but I did notice, John, that you talked a little bit about metformin as a drug that has promise. So maybe for our group here, describe that a little bit and the potential benefits.
So metformin is it's a treatment for diabetics to rapidly lower blood glucose by stimulating cells to uptake glucose and to metabolize that. And so it drives metabolism from a glucose perspective. And
interesting.
That typically happens in muscle and adipose tissue and things like that, which is why diabetics benefit from it, because it rapidly lowers serum glucose levels. And we found that in the retina itself can be responsive to metformin and can stimulate the retinal cells, the photoreceptors, the RPE, for example, to take up more glucose and to metabolize that and to generate different nutrients that they need to make them more resilient to degeneration. And it doesn't make them bulletproof, but it makes them more resistant to degeneration. And so what happens is they'll take out more glucose and they'll make more things that they need to survive, like molecules like DNA precursors or RNA precursors, or glutathione, which is an oxidative defense mechanism, or even NAD, nicotinamide replacement, can prevent a lot of the cell stress, the cell degeneration, because you're flowing more glucose through and they're metabolizing faster. That's one of the ways that we think it's working, but that's yet to be definitively proven. So
just a little bit of time for a few more questions. While there are only 10% of the population with geographic atrophy and 40% with intermediate AMD, what happened to the missing 30%?
It's probably a bit of numbers. So roughly 90% of any patient who has a symptom of AMD, that would be early and intermediate, are, so that's a very large pool. And then the 10% will go on to have something like an advanced AMD. This is some of the older numbers. And we start to get better with our statistics here and our definitions of what these are. Those numbers can change, but generally the older numbers were 90% in these early and intermediate AMD and 10% in these advanced AMD and neovascular disease. So I don't know, you might have better estimates on that than I have.
All right. Well, there's just a few questions. We'll be real quick, and then we do want to make sure we get. We always try to end right at 1 o'clock. Did I misunderstand? Is there wet component in dry MD or AMD, or does one have to do with the other? And that's always a confusing factor between dry and wet macular.
Yeah, it happens quite often that patients come in with neovascular or wet manifestations, and they're surprised to hear about it because they say, well, I thought it was only dry. And they haven't quite grasped that these are patterns of tissue injury that happen in advanced macular degeneration. The atrophy refers to the loss of cells due to cell death, and the neovascularization refers to damage to the macula through the misbehavior of blood vessels, but both patterns can happen in the same macula at the same time.
Thank you.
So hopefully that clarifies that.
Yes, thank you. And last one, are NSAIDs, ibuprofen, otherwise effective in reducing eye inflammation?
NSAIDs are used in certain contexts. They're used to treat certain kinds of inflammation, like scleritis, for example. NSAIDs work by targeting a chemical pathway called the cyclooxygenase pathway, but that's a different pathway, for example, from complement. Complement is potentially an inflammatory pathway, but it's not the pathway that NSAIDs target.
So it wouldn't have an impact on macular degeneration, but other inflammatory conditions potentially in the eye that could be effective for your doctor might prefer.
Typically more acute kind of conditions like scleritis.
Okay. Well, thank you both. This was a very, very good and very thorough presentation. I will let everybody know that all of these are recorded, so you feel free. You'll be receiving the recording in a couple days from our team, and you can share that with anybody. You can also review any of our webinars on the series through going to our website, which is www.eyeandear.org. Thank you all once again. Always enjoy doing this, and Dr. Dansingani, Dr. Ash, thank you for your time.